late on our Q&A, but we'll get started now, and we're going to go till about 1 o'clock with Dr. Khan. She's going to do just a couple of questions, and then she's going to run through a couple of cases that she wanted to share with you. So take it away.
Thank you. Thank you so much, Patty. So let's open up for questions, and then I've got some cases. Yes, please.
So I know all of us here are... Hold on. People online can hear you. Hello, I'm Liz. I know that all of us in the room, our patients are already stuck, but I'm just wondering, they came out with 3 different devices to detect parathyroid, so the incidence, I think, has dropped from like 10 to 4% of people who surgically end up with this. But I've read about immunotherapy for thyroid cancer, and it seems that it's just for the very rare ones, the medullary and some other one, and it's not a standard of care yet, and most of us got here through papillary cancer. And since there still is that 4% risk, or maybe it's higher depending on the surgeon, of ending up like us, what are they doing to look at immunotherapy for other people? Because every time I look at the Facebook group and I see the 5 or 6 people that join every month, or however often they list it, it breaks my heart. So what are they doing to prevent more of us from popping up? And do you see immunotherapy for the more common type papillary as possibly a better choice to avoid the risk we go through?
Yeah, that's a really good question. So patients who have thyroid cancer, different types of thyroid cancer, what are advances in treatment options that are going to be available? Well, one of the areas that the parathyroid surgeons are looking at is actually replacement of the gland itself. So transplant of parathyroid tissue, and looking at animal tissue or human tissue, transplanting this and ensuring that the gland will survive. So this is an area that is being evaluated, and we're looking at this in Canada as well. We're working with our colleagues at University of Toronto, and we're looking at having replacement tissue. Other areas that are undergoing a lot of research are immunotherapy and other modalities of treatment. But I would say that these are really in their very early infancy, and the most advanced right now are PTH analog therapy replacing the missing hormone. And also what needs to happen along with the replacement therapy is developing a technology that will allow real-time calcium assessments. Because, you know, we get patients to go to the lab and get blood work done. And if my patients aren't doing well, I give them a lab requisition. I say, get your blood calcium checked every day for the next 3 days. And then I'll base, you know, what's happening, and I'll make some small changes in the management, but I want to know what's happening with the calcium every day. And we'll call them every day, and I'd make adjustments so that we don't overshoot and we don't undershoot. But we don't have a real-time calcimeter. And if we could have a portable calcimeter that patients could check their blood calcium at home and say, you know what, my calcium is this. What should I do now? We could give them advice, and we could even give them algorithms. You know, do this. If your calcium is this low, then take this much active vitamin D and this much calcium and check again, and let us know what you're doing. And sometimes patients say, you know, I felt horrible last night, and I had all this numbness and tingling, and I had muscle cramping, and I couldn't move. And when they go in and check the calcium the next day, it's fine. But I don't know what that calcium was when they had those symptoms. So if we had a calcimeter that was portable and that was reliable, then that would be very, very valuable. And this is being developed in Canada. So right now we do have a company that is looking at developing a calcimeter. Life Labs is looking at this technology. We actually tested out one of their units, and at that time, you know, the technology wasn't ready for patient care, to be released for patient care, and this was a number of years back. So I'm hoping that we will have a valuable calcimeter in the fairly near future, because it's really great to develop all these new molecules for treatment of hypoparathyroidism, but without it being accompanied by improved technology to ensure that we have accurate real-time calcium measurements, we're really not being able to close the loop. and we need to be able to close the loop. We need to know, patient needs to know, this is my calcium, this is how I feel when my calcium is this, this is what I need to do, so that they can adjust their own supplements based on what's happening.
Okay, wait, Daniel, one more question? Yep.
Thank you. First, I just want to thank you for your presentation this afternoon or this morning on all of the PTH trials. It was very informative, and I appreciate all of the work that you've done. But my question is twofold. One of the things I haven't really heard is, through all of the PTH trials, the different ones that are going on, what are the risk factors or adverse effects of this drug on the population, and has it been found to be ineffective in any patients with hypopara?
And those are really, really good questions. So what are the harms of PTH therapy? Well, you know, the PTH 1 to 84, when it was used in 60 times the dose in rats, we saw an increased risk of osteosarcoma. But in humans, we haven't seen that, and the human skeleton is very different to the rat skeleton. We don't see that continual remodeling that happens, the continual bone modeling that happens in the rat. And in humans, we're not using 60 times the dose. So in humans, we have seen no evidence of increased risk of osteosarcoma, and the FDA has removed the black box warning, relinking the effects of PTH on osteosarcoma and the risk of osteosarcoma. Having said that, it is important that PTH analogs not be used in people who have had radiation to the skeleton, or who have Paget's disease, or who have cancer which has spread to the bones. So if there is cancer in the bones, or there's been radiation to the skeleton, we haven't looked at PTH in these patient populations. So in the studies that have been done, these were the people who were excluded. So we didn't include people who had cancer in the bones, or radiation to the skeleton, or who had Paget's disease. If they did have cancer and it was under control and it was not metastasizing to the skeleton, it hadn't spread to the bones, then that's fine. That is not a problem. But in these patients who have had radiation and who have cancer in the bones, PTH therapy hasn't been evaluated in these people. Also, it hasn't been evaluated in people who have, in the TransCon study, who have a GFR of less than 30 mils per minute. So if you do have a very low GFR, what do you do? Well, probably it would be fine, because we do have data with teriparatide, even in patients who have end-stage renal disease, and it can be very helpful in improving bone health. So I expect that it's not a problem. I expect that it would not be a problem in patients who have severe renal disease, but we don't have the data right now, so I need to explain that. And probably the drug would be safe in other patient populations where it hasn't been tested. But it hasn't been tested in those specific populations. In terms of safety, it seems to be very safe in all of the studies that have been done so far. No one has died because of the drug. There was one death in the phase 3 trial with the TransCon PTH, but it was unrelated, and it was because of a massive cardiac arrest that the patient had underlying heart disease and had reason to have a cardiac arrest, but it was not related to the drug. So nobody has died or had a serious adverse effect from the PTH molecule in any of the studies that have been done. So no one has died from it. All the side effects have basically been mild to moderate. They've consisted of injection site reactions or headaches. Some patients might feel lightheaded because it can make your blood vessels dilate, so it could cause your blood pressure to drop. And you could become, lightheaded on that basis. So if you feel lightheaded after your medication, the best time to take it is at night. So you're going to take your medication and then go to sleep. But if you do feel lightheaded, then, check your blood pressure at home. The thing is, we need to check the blood pressure at home and have it lying down and then have it standing up. and check to see if there's a drop in your blood pressure. And if there's a drop by more than 20 millimeters of mercury, that's an important drop. And you do need to tell your doctor about that, because you can develop what we call orthostatic hypotension. That means that your blood pressure may fall when you stand up quickly, or if you get out of bed quickly and you run to the bathroom, or you run to open the door or answer the phone. If you feel lightheaded, let your doctor know, because that is important. What about response? And, there's a variation in response. With the TransCon PTH, we've seen some patients requiring only 6 micrograms a day, and some patients requiring 60 micrograms a day. So there is a variation in response, and it doesn't seem to be related to the size of the person. So you could have a small lady requiring fairly large doses of PTH, and a hefty young guy requiring low doses. So everybody is different. Their response is different. And in one of the studies, some patients have required more drug therapy, and we've had to give calcium and active vitamin D in addition to maximum doses of drug therapy, because response has been limited. Now, why is it that it may respond in some and not respond in others? Well, we know that some people can have antibodies to the molecule. Are these neutralizing antibodies? We haven't seen that so far, that they would be an antibody that would bind to the molecule and eliminate its function and activity. But, we always have to keep an open mind and look at reasons why a patient may not respond to therapy or require higher doses, or they may simply require more than we've been giving them in that clinical trial. So that's an area that also needs to be explored. And remember, the science is still in its evolution, right? We're still learning more about it. We're still in its early days. We've come up with a molecule that has now been approved by the FDA, which is really welcome news, because up until now we were in a very bad situation with limited access to effective therapies, and having a TransCon PTH approved by the FDA is a tremendous blessing. So we're really delighted to see that, and we're hoping that it'll happen in Canada as well, that it'll be approved by Health Canada. It has happened in Europe, so the EMA has approved it, the FDA has approved it. We want to see it approved by Health Canada, and we are hoping that that will happen very soon, sometime in 2025. But right now, we don't have it approved by Health Canada at this point. So we're still in its early infancy, and we're going to continue to monitor people. So whoever's coming up to the completion of their phase 2, phase 3 trials with TransCon PTH, we do have the assurance that the drug is going to be available by the manufacturer for every single patient. That drug will continue to be available, and we've been assured by the manufacturer until the drug is available commercially in that country. And that's a big, big plus, and it relieves everybody's anxiety. So nobody should need to worry that, what am I going to do because I'm completing the study? What if I don't have access to therapy? We do have the assurance from the industry partners that they will continue to provide the drug for every single patient until the drug is available commercially in that particular country. So please ask your investigator if you have that concern, because that will be available for certainly all our patients in Canada, and I know that that will be the case also for the US and with other countries.
All right, very good. So we have about 7 minutes left. I think you wanted to share some case studies.
Yes.
Go ahead.
Okay, thank you so much, Patty. So I wanted to share a case of a patient that we looked at, and I wanted to say a little bit about pregnancy. And I know that there are young people in the audience and women who are planning a future pregnancy. My goodness, this is Here we go. And so I wanted to share a little bit about it. This is all about our guidelines. And in our guidelines, what was new in our guidelines that was not addressed in previous guidelines is the section on pregnancy and lactation. And these have just been published, and they involved extensive review of the literature. And so I wanted to share this case with you for the young people in the audience who are planning a future pregnancy and answer any additional questions as well from the guidelines. But this was one of our patients, and she had post-surgical hypoparathyroidism following surgery for papillary thyroid cancer that she had done at age 24. And now she comes to see us, and she's 32 years old. And she did have a pregnancy at age 30, and she did unfortunately lose that baby. And it's important to remember that patients who have hypoparathyroidism, if their calcium levels are low, they will go into premature labor because we need calcium for every single cell in our body. And so this, and oftentimes young women who present with hypoparathyroidism and are pregnant, they will say, yes, you know, I lost 2 babies before. I've had miscarriages before. And it's because the calcium levels, if they are low, that will result in premature labor, and it will contribute to complications. So this patient then goes through a pregnancy, and she was monitored very closely. And in the new guidelines, we talk about the importance of monitoring pregnant women every 3 weeks. So every 3 weeks, a pregnant woman should have their blood work done. And they need to have a multidisciplinary team approach. So the endocrinologist is following the patient. They need to be in communication with the OBGYN. So if that patient is having uterine contractions and we check their calcium and the calcium looks good, remember, you don't know what the calcium was like when they had uterine contractions last night because you don't have real-time calcium. So if my patient comes and tells me, you know, my calcium, I had uterine contractions a week ago, and then I will say, okay, well, I'm going to give you more calcium and active vitamin D because I don't want you to lose this baby. But even though your calcium looks normal, because I don't know what it was like, you know, previously, I'm going to check that calcium again. I'm going to monitor more closely, but I'm going to give them more drug therapy. And during pregnancy, we are saying that you need to continue with calcium and active vitamin D because we don't know about the safety of PTH and PTH analogs during pregnancy. So in our best practice recommendations that will be published next year, early in the next year, we are saying that patients need to be very careful about ensuring that their calcium in a pregnant woman should be in the mid-normal range or in the low part of the normal range. For the non-pregnant patients, we said the calcium can be below the normal reference range, just below the normal reference range, but it differs for pregnancy. In pregnancy, we want it to be in the mid to the low part of the normal reference range. We don't want them to be high, because if they're high, then the baby's parathyroid glands won't develop. And the baby is going to crash after being born. And so we have to keep the pediatrician aware of what's happening. So we need to work as a team. So if you are a young woman with hypoparathyroidism and you're planning a pregnancy, you need to have your endocrinologist, talk with your OBGYN, and preferably be seen at a high-risk center. And you need to be monitored closely every 3 weeks or even more frequently. And that baby has to be seen at birth. And the baby has to have the calcium levels monitored. So during the pregnancy, if the calcium levels are high, the baby's parathyroid won't develop. If the calcium levels are low, the baby's parathyroid glands will be hyperplastic. And their parathyroid function in utero will be high, and they might even break their bones in utero. There have been reports of fractures in the babies during pregnancy. If the patient's calcium levels are low, then the baby's parathyroid glands will become hyperplastic and cause primary hyperparathyroidism in the baby and in uterine fractures can occur. So during pregnancy, it is very important that we monitor our patient very closely. And I'm just going to skip a bunch of slides here that we have talked about. And I'm going to show you the numbers of, these are some of the ungraded recommendations that we said. So in pregnancy, in the guidelines, we said, keep the calcium in the mid to low normal reference range. Keep that phosphate, vitamin D, and urine calcium in that, monitor them closely, and ensure that the serum calcium is monitored every 3 to 4 weeks. And work closely with the pediatrician and the obstetrician and avoid PTH drugs and avoid thiazide diuretics. We can give calcium and we can give active vitamin D. And I just want to share the results of one patient. This is a patient who had pregnancy. And what happened, you can see, is the top bar, we have the trimesters listed here. And you can see that the requirements for the calcium and the active vitamin D vary during pregnancy. Now, during pregnancy, the breast and the placenta are producing PTHRP, which acts like PTH. So now the pregnant woman has a source of PTH, her own endogenous source. She is now producing PTH. Is that PTH going to be enough to help meet the requirements of the baby, the developing fetal skeleton? Because the baby skeleton is developing and the baby needs calcium. So the PTHRP that the pregnant woman is producing now may be enough to meet the baby's requirements, or it may not be enough. And so we need to follow these patients closely. And what happened to our patient is that you can see her calcium requirements actually increased, and the Rocal requirements went up in the 3rd trimester. She started off at 1,500 milligrams a day. By the 3rd trimester, she's at 3 grams a day. So her endogenous, her own natural PTHRP being produced by the breast and the placenta wasn't enough to meet the baby's requirements. And the dose of her calcitriol was initially 1.25 micrograms a day. At the 3rd trimester, she's at 1.5 to keep her calcium as close to normal as possible. And then what happens after weaning is, remember that the breasts are now going to produce a lot of PTHRP. So again, when women are breastfeeding, we have to watch them closely. And when they stop breastfeeding, that PTHRP goes down. So they might, when they stop breastfeeding, their calcium might drop like a rock because they're no longer producing that same amount of PTHRP. So during pregnancy and lactation, patients need to be followed very, very closely. The baby has to be followed very closely. This baby required NICU admission and watched closely because the baby's calcium may not be normal. So with that, I'd like to thank you for your attention, and no more questions because we're out of time.
Yeah, we're out of time. We could talk to you all day. Thank you.